Meenakshi has not joined, no? No, Meenakshi is not there. Dr. Krishnamurthy, how are the rains there in Chennai now this time?
Not too bad till now, sir. It will really start in November, December. No, mostly November. Late October, November is when we get our monsoon.
Okay.
And we are hoping that we won't get drowned this time.
Yeah. Well, I think last year or year before it was quite bad.
Yes, we've had a couple of very bad flood years.
Yeah. So, Dr. Mathur, in between you can speak in Hindi also.
Okay, I would try to communicate in both the languages, because
English and Hindi, because there will be mixed audience. So, and I think the answer should be simple because the audience will be mainly general public.
okay, I think that should be all right. So that should be all right.
So we'll wait for about 2-3 minutes and then we'll start. Dr. Nirmal Surya is a very enthusiastic and dynamic president. So the way he works and the way he conducts the programs, you get a feeling that where there is one Dr. Nirmal Surya, there are 4 or 5. He has an energy of 5 to 10 people.
I can tell you that right from the early days, from his student days, he has been like active like this only, involved with all the activities all around.
Yeah, you would have seen him from childhood.
Yes. And always trying to work for the public, basically for the common cause of public health issues or so. That is another important part, basically.
High energy, high impact.
Yes.
In fact, sir's public education epilepsy programs are really wonderful. So many patients come and share experiences. Very, very dynamic day of program in Mumbai.
Thank you all. I think we need to start the program now. Dr. Meshram, please.
Yeah. Dear friends, good evening. I am Dr. Chandrasekhar Meshram, Chief Coordinator of Public Education Activities by Indian Academy of Neurology, and I welcome you all for this session on dementia. Today is World Alzheimer's Day, and the public awareness campaign is run all over the world, not only today, but during the whole month of September. And I extend my best wishes on the occasion of World Alzheimer's Day. Today we have Dr. Nirmal Surya, who is the president of Indian Academy of Neurology, to inaugurate today's session. And we have distinguished faculty, Professor E.S. Krishnamurthy. He is from Chennai. And after doing the initial medical degree and MD, then he went to London for further training. So he's a behavioral neurologist and neuropsychiatrist. He founded the Buddhi Clinic, and also he's a founder of Neurokrish Foundation. And yes, he's a pioneer in integrated and holistic care and rehabilitation for brain and the mind. He has been the immediate past president of International Neuropsychiatric Association. And he is a prolific writer and is currently adjunct professor at Manipal University and Health Foundation of India. Welcome, Dr. E.S. Krishnamurthy. He's a moderator today for the session. And we have faculty, Dr. Arvind Mathur from Jodhpur, Dr. Subhashri from Nimans, Bangalore, and Dr. Jwala Narayanan from Bangalore. So welcome all the faculty. And once again, I welcome you all. And I request IAN President Dr. Nirmal Surya to say a few words. Dr. Nirmal Surya.
धन्यवाद डॉक्टर मेश्राम. नमस्कार. आज की शाम जो एक स्पेशल अवेयरनेस प्रोग्राम वर्ल्ड अल्जाइमर्स डे के ऊपर हम लेकर आए आप लोगों के लिए, और उनमें जो एक्सपर्ट है जो इस फील्ड में बात करने वाले हैं, वो आपको इस बारे में जानकारी देंगे कि क्यों हम इतने कंसर्न हैं अल्जाइमर डिजीज के बारे में, क्यों इसका निदान जल्दी कर पाना या पिकअप जल्दी कर पाना जरूरी है, क्यों हम अर्ली डायग्नोसिस नहीं कर पाते हैं और 3-4 साल 5 साल या काफ़ी टाइम निकल जाता है जब घर वालों को यह मालूम पड़ता है कि अब तो बिल्कुल स्थिति गड़बड़ हो गई है, और क्या नए ट्रीटमेंट को चेंज कर पाएंगे ये बीमारी के लिए, और क्या फ्यूचर में ये बीमारी ज़्यादा होगी या इसको हम रोक पाएंगे. तो ये सब चीज़ों के बारे में हमारे जो एक्सपर्ट पैनल है डॉक्टर मेश्राम ने बताया, वो आपको बताएंगे. अल्जाइमर डिजीज जो है ब्रेन डिसऑर्डर है, जिसमें ब्रेन उम्र के साथ में मेमोरी का डिस्टर्बेंस होता है, बिहेवियर डिस्टर्बेंस होता है, हालांकि मोटर फंक्शन नॉर्मल रहते हैं. तो ये बीमारी के बारे में क्या लक्षण है, क्या कैसे डील करना है, उनको किस तरह से अर्ली डायग्नोस करना है, इसके बारे में आपको पैनल बताएगा. और मैं आप लोगों को यह बता दूं कि इंडियन एकेडमी ऑफ न्यूरोलॉजी लगातार यही प्रयास करती रही है कि हम हर दिन जो भी इंटरनेशनल या नेशनल इम्पोर्टेंट डे है, उस दिन आप लोगों को उस बीमारी के बारे में जानकारी दें, और हम बेस्ट पैनल को यहाँ पर उनका एक्सपर्टीज को लाते हैं ताकि वो आपको डायरेक्ट बता सकें, आपको कोई भी चीज़ के बारे में गलतफहमी ना रहे. और इसके अलावा भी आप कभी भी जो फीडबैक है या ईमेल है आप लिख सकते हैं. और आपको ये सारे, अगर आपने मिस भी कर दिया है, तो ये सारे प्रोग्राम इंडियन एकेडमी ऑफ न्यूरोलॉजी की यूट्यूब चैनल पर मिलेंगे. आप सब्सक्राइब करिए और उसको देखते रहिए और ये जानकारी लेते रहिए. इन शब्दों के साथ मैं आज के जो मॉडरेटर हैं डॉक्टर E.S. कृष्णमूर्ति, उनको हैंड ओवर करता हूँ, क्योंकि वही जो पूरे प्रोग्राम को आज चलाने वाले हैं. Welcome, Dr. E.S. Krishnamurthy, and all show is yours.
Thank you, sir. Thank you, Professor Surya. Thank you, Dr. Meshram. It's an honor to be doing this with Indian Academy of Neurology, and we have very distinguished faculty joining us. Professor Arvind Mathur, he is ex-principal and controller, professor of medicine, Dr. SN Medical College, Jodhpur. He is editor of the Journal of the Indian Academy of Geriatrics, and he is director and managing trustee of the Asian Center for Medical Education research, and innovation. He is a very senior teacher and public health educator who's been very active in public health. Welcome, sir. We will be talking to you about the various public health issues in geriatrics. We also have with us today Dr. Subhashri from NIMHANS. She is the additional professor in the Department of Neurology and Fulbright Nehru Academic and Professional Excellence Fellow in Brain-Computer Interface. She has interests in stroke, cognitive and behavioral disorders, and she's part of the cognitive neurology team at NIMHANS with many publications and many projects. We also have with us today Jwala Narayan, who's a consultant neuropsychologist from Bangalore. Her areas of interest are neuropsychological rehabilitation, bilingualism, and memory. And she has been running a unique enrichment program for people with dementia called CogWorks. So welcome to all our three panelists. I'd like to start by asking Dr. Mathur, in the context of a geriatric clinical practice, with what frequency do you see memory concerns? And as a geriatrician, what makes you suspect early dementia in a person who's consulting you?
Thank you very much, Professor Krishnamurthy, for having me, and Professor Nirmal Surya and Indian Academy of Neurology to have me with distinguished panelist and distinguished specialist. Now, in geriatric practice, as with the age, we tend to have so many morbidities together. तो उम्र के साथ में बहुत सारी बीमारियां एक साथ हो जाती हैं और उनमें से एक चीज को पिक करना थोड़ा सा डिफिकल्ट होता है, परंतु जब भी हम किसी ओल्ड पर्सन को देखते हैं एंड अगर वो खुद अपनी एंड पे ये बताया कि उसको याददाश्त में कुछ फर्क आ रहा है या उसके फैमिली मेंबर्स या केयर गिवर्स ये इन्फॉर्म करें कि उनकी याददाश्त में फर्क आ रहा है, तो उनके लिए हम वो जांच के लिए प्लान करते हैं। पर इस सब के लिए हमारे यहाँ पे जेनेटिक प्रैक्टिस में एक स्क्रीनिंग मॉडलिटी है जिसमें कि हम जो इंट्रिंसिक कैपेसिटीज हैं बॉडी की, जिसमें कॉग्निशन सबसे इम्पॉर्टेंट है, उसका एक सिंपल एक स्क्रीनिंग टूल अवेलेबल है जिसको हम हर एक ओल्ड पर्सन के लिए अप्लाई करते हैं। एनीबडी अबाउट 60 years of age would definitely be asked about memory lapses, और उनको एक 3-word recall जो टेस्ट है, which is a very simple and sensitive test, वो हम हर एक पर्सन के क्लिनिकल इवेल्युएशन में इट इज इंक्लूडेड। सो जेनेटिक प्रैक्टिस में मेमोरी इज अ वेरी इंपॉर्टेंट एरिया, कॉग्निशन इज बहुत इंपॉर्टेंट एरिया है। इसके लिए हमें एज ए जेनेटिक प्रैक्टिशनर्स वी ऑलवेज आस्क अबाउट मेमोरी टू पीपल, और जो हमारा इवेल्युएशन है उसमें जो फर्स्ट स्क्रीनिंग स्टेप है वो हम जरूर करते हैं। 3-word रिकॉल का टेस्ट जो है, अगर उसमें कोई प्रॉब्लम आती है तो देन वी रेफर इट फॉर द फर्दर इवेल्युएशन और सो। नाउ व्हाई इट इज इम्पॉर्टेंट इन दिस एज? विद द एज ये देखा गया है कि अल्जाइमर्स डिजीज का जो इंसिडेंस है वो एज के साथ बढ़ता है, and almost every 5 years it doubles. Say 60 to 65 में 1% है, तो 65 to 70 में 2%, and by the time people are above 85, more than 35% would have Alzheimer's disease. So age के साथ में memory lapses and जो dementia की prevalence बहुत ज़्यादा है. That's why as a geriatric practitioners, we are always looking for memory lapses, or memory evaluation is a part of our फर्स्ट स्टेप स्क्रीनिंग इवैल्यूएशन इटसेल्फ। तो मैं जो हमारे पास में एनीबडी हु कम्स टू अस, वी ट्राई टू स्क्रीन देम फॉर दिस पर्टिकुलर थिंग।
Thank you, sir. So what you're saying is that while many medical conditions may exist in an older person, it's very important to focus on memory and test memory in older people, because as people get older, dementia is a common problem. I'm going to ask Jwala now. Can you tell us, Jwala, about memory per se and what stages of memory loss you observe in your patients?
Yeah, thank you. Firstly, I'd just like to thank IIN for this invitation. It's really quite an honor to be sharing this panel with all of you. So when I'm a neuropsychologist, and what we do is, I think we do quite the painful aspect of testing. And, some patients have to go through a few hours of memory testing and also testing of other cognitive abilities. So when we look at the different stages of memory, the very early stages is actually can be quite benign, or it can, doesn't seem very real. And a lot of it gets passed off as normal aging. So someone can have word finding difficulty or forgetting appointments or misplacing things. And I think the key sign here is when it happens consistently. If you forget something and you're not able to recall it later, and just doesn't come back to you, and that's the key sign when there is something to probably worry about. But I feel as people get older, we all do forget, we all do misplace things. And these days, especially because we're all multitasking so much, there is a lot of cognitive overload, which does lead to these problems. But I think in the early stages, it can be hard to differentiate. And we don't see so many of them in the clinic because they come at the next stage. So in the early to sort of moderate stage is when they have a little more significant, what we call as recent memory. So forgetting who came home yesterday, or an event that had happened quite recently. They went for a wedding and they just don't remember who they met there. Forgetting details of things that have happened, or they've given money to someone and they forget they've given that money. So that's the more sort of early to moderate stage that we see in terms of memory loss. And then when you look at a more moderate to severe, where, looking at consistent forgetting, sometimes they can be quite disoriented. They don't know what date it is. They also forget names of close family members, sometimes also fail to recognize them. And also what we call as overlearned things, like, their favorite recipes that they cook, that also tends to break down. So they're not able to cook anymore. So that's in the more sort of severe stages. But I just like to highlight, one thing that we're learning more about the different dementias is it's not just memory. And sometimes it's quite important to pick up the other signs that get missed and people come in much later. So people can have problems with also language. So word finding is one, of course, but also, their fluency in speech can be different, or they have difficulty just uttering words. Also visuospatial difficulty, so they can't find certain rooms or things that are right in front of them, or they get lost. Also motor difficulties, they have difficulty walking or doing certain activities which are physically, you need to move your hands in a particular way, like we call it apraxia. So those kind of things can be looked out for. And of course, one of the biggest changes that get put off again as old age is behavior change. Patients and their families come and they say that this is just not my mother. And that's actually one of the early signs of dementia as well. So just wanted to highlight that.
Thank you. So comprehensively speaking, even if in a subtle situation, if someone is repeatedly forgetful, it is cause for concern.
Yes.
And as memory loss progresses, the disability or the difficulties increase. And it's not just memory, but it's also language, the ability to do things effectively, behavior. All these things should concern us.
Yes.
Thank you. I'd like to ask Dr. Subhashri. We talk often of mild cognitive impairment today, and we think of it as something like impaired glucose tolerance. Why is mild cognitive impairment important? And could you please tell us a little bit about that?
Yeah, thank you. Thank you for the opportunity first to IE, and thank you, Dr. ESK. Mild cognitive impairment, as the name suggests, it is one of the early stages of cognitive decline. And it is something which is more than normal aging and something which is before the commonly used term dementia. So what is important is there is a change from the normal way of living the person had, and it is a noticeable change. So as what Jwala was mentioning, it could be something like misplacing objects or word finding difficulty or forgetting some of the important events or moving around, navigating. So they also have this, but What is important is they are independent for their daily activity. So that is what is the key point that differentiate MCI from dementia. So one is able to still carry out his daily activities, unlike in dementia where the person is completely dependent on the caregiver or the family for their daily activities. So that's the main difference between MCI and dementia. And there are different varieties of different types, generally the amnestic and the non-amnestic. So when we say amnestic, it is something which deals with the memory. And when we say non-amnestic, so the person is no more able to take a main decision, no more able to plan or judge or navigate or has some language difficulty. And there are several causes starting from nutritional or infective trauma, or it could be even depression and neurodegeneration. And Alzheimer's is one cause of the spectrum of this MCI. Now, what is important? Why MCI is important? There are two things. One, it is important for early detection, and around 1/3 can be reversible. They can become completely normal, and 1/3 can remain in the same way as they are, stable for several years, and the other 1/3 can progress and develop neurodegenerative disorders. So this 1/3, which can be reversible, that is important and crucial. And also in the MCI due to Alzheimer's, now with the newer therapies coming up, this stage is very crucial. And this stage is one stage where we can advocate and help them by following several preventive measures. So starting from a simple BP correction to vascular risk factor diabetes correction, we can tell them to go for a walk, a jogging, or a swimming. We can supplement them with B12, and we can ensure that they wear a helmet and avoid a head trauma. So many preventive strategies are possible at this stage of MCI. And so that is why MCI is very, very important and crucial to identify.
Thank you. So they do have the problems of a person with dementia, like forgetfulness and things like that, but they retain their independence in their activities of daily life. And MCI is a very important opportunity to treat, and hence it's very important to diagnose. Thank you so much, Dr. Bashir. Dr. Mathur, sir, as a geriatrician seeing older people, what medical conditions would you wish to rule out when you see a person with suspected dementia?
Yeah, as mentioned by Dr. Subhashri, dementia always doesn't mean that, or cognitive decline always doesn't mean it is dementia. There are certain reversible or the treatable medical causes itself. So whenever we have a person presenting to us with some memory lapse or some cognitive dysfunction, we try to look at certain common ailments, and they are quite frequent, like thyroid disorders. Both hypo and hyperthyroidism, they can give rise to this problem. Drugs, so many drugs. They could be common cardiovascular medications, maybe anticonvulsant or psychotropic drugs, etc. So drugs are another important cause for cognitive dysfunctions. In addition to this, some nutritional deficiencies, particularly vitamin B12 deficiency, which is quite common in vegetarian individuals or so. So we try to look for vitamin B12 deficiency also. Certain infections like HIV or neurosyphilis, or certain CNS problems like encephalitis or so, they could also present with cognitive dysfunction itself. The use of alcohol or other toxic materials, particularly heavy metals, etc., they could also lead to cognitive decline. So, and there are other conditions like normal pressure hydrocephalus and other conditions which could also lead to a presentation which mimics dementia. As a geriatrician, which I always feel that probably our practice is the gateway for getting people moved to a correct direction for further evaluation by the specialist or the further future management. So our task is to identify these causes first before we label them to have a Alzheimer's disease or some other form of dementia or so. So whenever these patients come to us, we have a battery of investigations, which is important, which would include all these tests to look for these common problems. One, imaging by way of CT or MRI has to be done so as to look for reversible or treatable causes like even subdural hematomas or normal pressure hydrocephalus, etc., could be looked into. Besides the investigations, I'll put it that having a good history is important. And we want to see whether the disease has been there for a long time or it is a recent onset disease. Because if it is a recent onset, then we are probably not dealing with a degenerative disorder or a dementia, but probably we are dealing with some medical ailment. Because as has been mentioned by Dr. Subhashri, management of the cardiovascular risk factors, the vascular events, they itself are important for cognitive decline also. So task of a geriatrician is to take out all these conditions before labeling anybody to have Alzheimer's, that or any other form of dementia. And these are potentially treatable and reversible causes, which could be helped by proper management in time. So that is what is we try to do whenever somebody comes to us with cognitive decline also.
Thank you, sir. So there are a number of medical causes. There are also potentially drug-related causes and even occupational exposure or toxic substances, including use of alcohol and other habit-forming drugs, which can contribute to a person presenting to you with memory loss, and you would like to thoroughly evaluate them for all these. Dr. Vikram Datta has correctly pointed out that falls are common in older people, and sometimes they present with memory loss due to a subdural hematoma, and that needs to be kept in mind as well. Thank you, sir. Jwala, can I ask you a little bit about how you go about doing memory testing and why it is important?
Sure. So I think when people get referred to us for testing, it's primarily to understand their cognitive abilities. So what a cognitive assessment is, basically there are a bunch of paper and pencil tests at the moment. Now we've started using computers as well. But it's nothing invasive. There are no injections, we don't poke you. But what we're trying to do is trying to assess the functioning of the brain. So I always tell patients, like how you have an MRI, it tells you how the structure of the brain is. So the testing that we do tells us how the brain is functioning. And basically what we're trying to do when we're trying to come to a diagnosis of dementia or rule out a dementia is trying to see if it all sort of correlates at some level. So I think like Dr. Mathur was saying, one of the very key things is a very good history. So, I spend a lot of time, at least an hour, just sort of taking history, because that gives us, a big clue on what this might be, whether this is dementia or not. And then we sort of go into the cognitive assessment. So when we look at cognitive assessments, we're looking at different aspects of the brain, because like I said, memory is the most common, but we also have other cognitive functions that can start to degrade in dementia. So we look at language abilities, so word finding difficulty, if they're able to read, if they're able to write. We look at memory, and even memory, it's different types of memory. So I might give them like a list of words and then try to recall that a little while later. Sometimes we give them things to draw. We show them pictures and then ask them if they remember seeing these pictures. We also do some tests to look at their executive functioning, as we call it, like being able to do some reasoning and problem solving. So that gives us an idea of how those abilities are. And visuospatial abilities as well. So being able to draw or being able to see things in space. So these are some of the core areas of cognition that we test. And then, of course, we do a few tests to make sure we rule out depression or anxiety, because that's a very, very important area that gets missed in older people. If someone is depressed, if someone is anxiety, you're definitely going to have a poor cognition, you're going to have memory problems. So I feel trying to rule that out is one of the key roles that we play. So a lot of our testing helps in differential diagnosis. So trying to see what kind of dementia this is. Is this dementia or not? Is this something that looks treatable, reversible, so we can monitor them later? So if we think this is something that's reversible, if it's thyroid, fix the thyroid, 6 months later, we assess them again to see if they're better. So then we know that, okay, it's not really dementia. And also, I think it gives us a lot of information that we can then counsel the family as to what I think we focus so much on what they can't do. So these tests help us also tell them what they can do and to sort of focus on that. And also, prognosis, telling them where this might go, how it might be. And I think that psychoeducation is extremely important for the family at this point. So this is what our assessment does.
Thank you. So what you're saying is that the time spent in the psychologist's office gives a very detailed picture of the person and how they are functioning, what still works well, what does not work so well, yes, and why it is not working so well. And it may aid both diagnosis and prognosis. And therefore, it's important that people go through that exercise, even though it's time consuming. Yeah. Thank you. We're marking World Alzheimer's Day. And while we focus on Alzheimer's, of course, there are other things that we should focus on also. So I'm going to ask Dr. Subhashri to tell us what is Alzheimer's disease and how do you differentiate it from other common and important forms of dementia that we come across in clinical work.
So, as you mentioned, on the World Alzheimer's Day, Alzheimer's dementia still stands number one in the cause of neurodegenerative dementia. And it is a progressive disorder. So there is a degeneration of the brain in specific parts of the brain, and the symptoms are based upon the areas of the brain that are shrunken or atrophied. So how do they manifest? They manifest with recent memory disturbance. For example, they would have conversed something, they will forget their conversation. They would have taken their breakfast, they will say, I have not taken. They may have difficulty in finding places, even within the familiar areas. They may have difficulty in calculation. He may be a very good bank accountant, but the family will say he's no more able to identify, he's no more able to give the money or calculate the money. And they may have difficulty in naming things or even their loved ones. They may have difficulty in wearing dresses or buttoning them. So these are some of the clinical presentations that they may come up with, or they may even have other behavioral problems like anxiety or depression. So these will be a combination of different clinical features that they come up with. And it is mainly because of the abnormal pathology. One is the intracellular tangle, we say, and the other is the extracellular amyloid block. So these are the abnormal proteins which make them have these disease. Now, what are the risk factors? So who are prone for this? So it is generally seen in more than 65 years, women, patients, people with low literacy, or someone with the ApoE allele, so genetic predisposition, head trauma, so and vascular risk factors. So these are the risk factors for predisposing for Alzheimer's. And in an Indian setup, we are also seeing a lot of young onset Alzheimer's. Genetic predisposition is also common, and as high as 25% of the overall dementia group can be early onset dementia as well. So these are the presentations, and we diagnose them based on the clinical features. Then we do a formal bedside assessment, as what Jwala was mentioning, simple bedside or a paper pen test. And then we do a detailed cognitive assessment. And then we come to a conclusion whether it is MCI or whether it is Alzheimer's. And then we subject them to some of the investigations like CT brain, and then some of the blood investigations, and sometimes even the CSF analysis. And then we put together everything, the clinical history, the profile, and then we make a comprehensive diagnosis of Alzheimer's disease. And there are various preventive measures, and there are treatment available in some of the early forms of Alzheimer's as well. Now, this is Alzheimer's. Now, how do we differentiate from the other types? So the other types commonly which we encounter in the clinics is the vascular dementia. Then we have the frontotemporal dementia, and then we have the Parkinson's dementia with Parkinson's disease with dementia, the corticobasal syndromes. And so these are some of the common types of degenerative dementias which we come across in the clinic. So frontotemporal dementia, they come with behavioral changes or change of personality. So somebody may be very apathetic. Somebody has to be coaxed to do some of his daily activities. Repeatedly, the family member has to say, go have a bath, go have a food. So they will be amotivated, they may be apathetic, or on the other spectrum, they may be irritable, they may have anger outbursts, or there could be various personality change. And there may be like unconcerned incontinence. They may start having some stereotypic behaviors, repetitive behaviors. So all these abnormalities which we may see in behavioral variant FTD, and along with that, they will also have memory disturbances. Whereas with the other common differential diagnosis of Alzheimer's, which is the dementia with Lewy body disease, where they also present with memory disturbances, but along with that, they'll have gait difficulties, they will have slowness of activities, they may have psychotic features like hallucinations. So they may say, I'm seeing some things when things are not there. They may be hearing some things when things are not there. They may have sleep abnormalities. So that will be the spectrum in DLBD. And with Parkinson's disease dementia, they may be having Parkinson's syndrome, or they will have one-sided tremors, slowness. And these patients over several years, then they may develop memory disturbances. So that is PD dementia. So these are so based upon the type of the cognitive domain that is involved, the way it started, the way it evolved, and then corroborating with the imaging and other investigative reports, we come to a final conclusion. So that is how we do in the clinics.
Thank you. So apart from Alzheimer's disease, you're saying there is Parkinson's disease, related dementias, there is frontotemporal dementia, and there is vascular dementia. And in all these instances, the clinical history is extremely important, as also our examination and tying up the various findings, because our approach to treatment may be slightly different in these different situations. Thank you, Doctor. It falls upon me to just talk briefly about behavior. Jwala alluded to depression as an important differential diagnosis in older people presenting with cognitive impairment. And I think that late life depression is extraordinarily common and can be very treatable. And it can be the cause of a person presenting with either behavioral change, personality change, or indeed even cognitive impairment, including memory loss. So depression needs to be looked for and either confirmed or excluded, because that does change the prognosis quite a bit. Depression can be comorbid to various types of dementia, in which case they will have the dementia, but they also have depression as a complaint alongside. But when you look at behavior in dementia, and behavioral and psychological symptoms are extremely important, because very often that's what brings people to the doctor. A little forgetful older person, people tend to, be okay with. But the moment someone's behavior changes, they are immediately concerned. And that's when they seek help. And behavior can change even in mild cognitive impairment. It does not have to be advanced dementia for behavior to change. The behavioral profile that we see is threefold. And when we look at it from the neuropsychiatric inventory, which is what we commonly use to kind of describe behavior, one set of behaviors are agitation, irritability, and restlessness, that kind of behavior. Another set of behaviors are hallucinations, delusions, and sleep and nighttime behaviors, a lot of disturbance at that time. And the third set of behaviors, the third cluster really, is apathy, depression, anxiety, and withdrawal. And very often people present with more than one cluster. So it's important to always ask about behavior if the information is not volunteered. And sometimes you may want to talk to the family in private because they feel embarrassed to talk about it in front of the patient. So it's very important to gather this information in a discreet way, because that can often be the difficult part of managing a person with Alzheimer's disease or any other form of dementia. The one other thing about behavior is, of course, that behavior can contribute to the diagnosis. So the pattern of behavior that you see, and when you see the pattern of behavior, can also be a marker of which type of dementia the person is presenting with. So those are a few things that we may want to keep in mind about behavior. We have questions coming into the Q&A box, and we'll take those questions in the end. I'm going to continue talking to our panelists. So Dr. Mathur, sir, from a national policy perspective, because this is an area you're interested in, how should we organize ourselves to incorporate early diagnosis and treatment for dementia as part of geriatric care?
I think this is very important because we also realize that we have to address this problem looking to the population aging. The number of the older people in our country is increasing, and we are going to have a large proportion, by almost 13% of our population would be above 60 or so soon. So Government of India started a national program for healthcare of elderly, and there itself it was also realized that we have to look at the cognitive decline. World Health Organization, because they have been now having, the United Nations has got a decade of healthy aging. We are already in that. So the World Health Organization in 2017 introduced one important way of approaching the problems of the older people, that was called ICOPE, that is Integrated Care for Older People. Now, ICOPE has one important thing, that we are trying to look at the intrinsic capacity of that individual and the functional ability of that individual. And in intrinsic capacity, the cognition is one very important thing. So in that, they have already planned a screening tool or so. So Government of India has already taken up this task of at least approaching once everybody above the age of at least 75 to be screened with these screening tools, where in those screening tools, there would be two questions about cognition. One is three-word recall, and second is orientation about time and place. जैसे हम उन सबसे पूछेंगे कि आप वो words याद कर सकते हैं कि नहीं, और they know about their place और आज का date कौन सा है. So ये screening tool में ये part जरूर आएगा. And in case once we identify somebody with a cognitive decline, so then he will be put into the track for the further continuity of further evaluation. And in that, the plan is that at the primary health center, they would have a second step evaluation by way of using tool like Minicog or MMSC. And once if there is an abnormality found over there, then they will be referred to the appropriate for further appropriate management also. So this is one thing which Government of India is already planning. In policy, they have taken a cognitive decline in older people as a very important issue. That is one. Secondly, we are also having one very ambitious study, that is longitudinal aging study of India, LASI. This is being done with the help of NIH, Harvard School of Public Health, and Government of India, Ministry of Health also. In LASI, we are having a national representative sample. Out of that, about 3,000 subjects are being evaluated for diagnostic assessment of dementia. So this LASI DEAD study is going to give us a lot of information, because this is going to be a representative across the country, and it would also include some imaging studies of those persons. So these studies would give us clues for further interventions at the national policy level also. So this is one thing. Third thing which I like to mention is that we have been realizing that caregiving of the patients with dementia, the older person with dementia, is very important issue. And in our policy itself, we are trying to highlight support for the caregivers as an important aspect which has to be looked into, because this particular area is one of the very crucial areas for management of these patients. Thank you.
Thank you, sir. So what you're saying is that aligning ourselves with WHO policy and recommendations, using simple screening tools as part of our regular practice, and the lessons that we are going to learn from our own national studies that are ongoing, all of these will contribute to the future policy on dementia in India. And thank you so much for highlighting the importance of caregiving, because I think this is such an important aspect of dementia management. And caring for the caregivers is something that all of us ought to be also concentrating on while we think about our patients with various forms of dementia. Thank you, sir. Jwala, can I ask you about some simple psychological techniques that you use in order to rehabilitate the elder with dementia?
Yeah, so I think, one of what we've been doing for the last few years is really looking at what can we do after we give a diagnosis of dementia. And I think our learning has been there is a lot that can be done, and it doesn't all have to be scary and dark. So we run a center called Cogworks at our hospital, and we've really learned and seen that just activity-based cognitive exercises can be very, very helpful. So a lot of the exercises that we do at the hospital is things that patients have probably already been doing all their lives. So we look at their hobbies. So if it's stitching, or we also introduce new hobbies like art and painting and craft work. So what we sort of try to do is to keep whatever abilities they have, and try to see if we can build on some new skills. So, and the more purposeful these activities are, the more engagement you get. So we, of course, recommend the usual luminosity, or, doing some online games, or doing some little activities, cognitive exercises, Sudoku or Scrabble at home. But at the same time, what we find is just engaging in your everyday life at whatever level they are able to do is much more meaningful than sitting and, maybe just playing Scrabble. So, because then they also feel that they're involved and they still have purpose in their life. So I always tell them that if a patient can't cook a complete meal, that's fine. If they can do cutting, if they can do peeling peas, if they can do wiping a dish, whatever level they can engage with at home, that is very, very important. And apart from that, anything that engages them, keeps them busy is really important. And it shouldn't be a passive exercise. So watching TV is very passive. But if they're watching TV and then you're asking them questions about it, or you're having a discussion around it, then that becomes a non-passive exercise. So similarly, reading something, but just reading the headlines is not enough. So when they read a news article, maybe trying to engage and ask a few questions about it, making them write something about their past. So one thing that a lot of patients with Alzheimer's especially have, their old memories are quite nice. So I always suggest them, writing something from the past, maybe a holiday they've had, a nice memory they've had. The couple can sit together and write about it. So anything that gives them a little joy and is cognitively stimulating is something that we recommend. So it can really be, I think, when you sit down and then think of what can we do, I think the list can just go on. So there's no one particular exercise that is foolproof and that helps, slow the progression. I think it's doing everything. And we also know that socializing is very important. And we found that these group therapies, so group sessions, and if you're not able to get to a group, that's fine. But if you can at least try to do, like once or twice a week, a family get together, or just go down to the park and have, some group of people that meet regularly, because we've seen that even someone with dense amnesia, when they start to do something regular, it goes into their procedural memory and they can actually remember those people's names and what they did with them last time. And this is even in the moderate to severe stage. So I think it's really important to have that group activity for them. And apart from, the cognitive stimulation and the group exercises, we also suggest physical exercise is extremely important. And I'm saying this as part of, the cognitive abilities, because they all go hand in hand. So we see that, and we know this, that even patients with Alzheimer's, that once they start walking more, they become more alert. So their memory is better. So just making sure that they get enough physical exercise. And again, I always tell patients that, and their families, that they don't have to go for a 1 hour walk or, even a half an hour walk. But if they can do 10 minutes in the morning, 10 minutes in the afternoon, maybe another mid-evening sort of walk, and then again in the evening. So getting more physical exercise. So just making sure that your body is getting up. And I think what we tend to forget is that the patient may not be able to direct this behavior on their own. So we need to put it into their routine, and we need to make sure that we are reminding them to do it. And also other things like maintaining their diet is something that we do tell families as well. So making sure that they're eating well, healthy diet, less sugar, less oil, the regular lifestyle advice that we usually give is something that we advise as well.
Thank you. So it's got to be interesting, it's got to be engaging, it's got to be participatory, and we need to set up a kind of a rhythm of activity for the older person with dementia as a way of keeping them healthy, both from a mind and a body perspective.
Yes, absolutely.
Thank you. Dr. Subhashree, can you tell us the role of medical treatment for dementia, and what are the new drugs that are available which are causing a bit of excitement for everyone?
So the medical management includes some of the drugs like cholinesterase inhibitors, the donepezil, memantine, galantamine, rivastigmine. So these are drugs which are orally available in a tablet form, and for transdermal patches for rivastigmine is also available. So these are some of the drugs that are already there, and these are mainly used in the early or the mild to moderate stages, where they are shown to prevent the rate of decline in the cognitive function of these patients. And that apart, there are other drugs for behavior and psychiatric manifestations, but a rational usage of them is very important in these Alzheimer's dementia group. And as you had mentioned rightly, that the sensational drug, that is the first ever disease modifying agent that is approved by FDA, which underwent a fast approval, unlike the other conventional path was the aducanumab. So the monoclonal antibodies. So
we seem to have lost Dr. Subhashree to a power fluctuation. So I'll just probably talk about one or two things which we intended to talk about as well. The behavioral management, Dr. Subhashree was mentioning the use of psychotropic drugs. The only thing with psychotropic drugs are that we know consistently from research that use of psychotropic drugs in dementia adds to the morbidity and mortality. And therefore, the use of the primary drugs that Dr. Subhashree mentioned, like the rivastigmine and donepezil, along with memantine, is safer than using a psychotropic drug separately. We have Dr. Subhashree back. Dr. Subhashree, please continue.
Yeah, sorry. The latest drug in the market is aducanumab. It is not yet available in India because there are specific requirements for the same. It's a monoclonal antibody. So what they have shown is using PET and amyloid PET imaging. They showed that aducanumab is able to clear the amyloid pathology, and that's how they got the FDA approval. So the long-term clinical outcome, we'll have to wait and see. And it is available in an IV format. The subject has to take once a month, and as of now there is no clarity as to how long they have to take. It's some of them say even 18 months they'll have to take, and one has to watch out for the amyloid associated abnormalities in the brain, follow them with the MRA, make sure that there is no bleeds in the brain, no edema in the brain. So these are some of the things that are coming up. And in the World Alzheimer's report that was launched a few hours back by the Alzheimer's Disease International, so there is a write-up by Cummings where he has mentioned that to the low income and the middle income countries, so what next if PET MRA is not there and amyloid imaging is not there? So how are we going to get aducanumab? So in that scenario, there's the evolving the plasma biomarkers that has come up with the p-tau and the amyloid 42/40 ratio. So these are some of the plasma biomarkers. Even at NIMHANS now, we have started up with this plasma biomarkers. So that can be an alternate option. And so a proper medical infrastructure is required. And most important, aducanumab can be given only in the MCI stage or the early Alzheimer's stage. So that's one important thing. Then other monoclonal antibodies like lecanemab and donanemab. So these are in phase 3 trials. And then there are drugs that act on the synapse like the saracanitinib. And then there is also underlying pathology of chronic inflammation that has been propagated as one of the mechanism. So people are also working on drugs like the sargromastib. They are quite complex, these names are, but these are all in the pipelines. And there are also tau. People have also looked into the alternate pathways. So why not the tau pathology? So they have looked into tau vaccines and tau aggregation inhibitors and the beta and the gamma secretase inhibitors. So they have tried to see, look into the different pathology and the drugs which can act across different pathology. But as on date, the first ever DMT that is approved is aducanumab. And so these are some of the drugs in the horizon, raising the hope for these patients with Alzheimer's disease.
Thank you. We have, therefore, a lot of excitement in store for us when it comes to the treatment of dementia over the next decade, isn't it? It's going to be different from the last one. Thank you. We have two unanswered questions in the box, and I'm going to let Dr. Subhashi take both. One is there a senile dementia, and how do you differentiate it from a primary dementia? The other is, how do you improve sleep in dementia? We can't hear you, doctor.
Yeah, sorry. So when we say senile dementia and dementia, so same thing. It's like a spectrum. The normal aging, the mild cognitive impairment, then we have early Alzheimer's, the mild disease, the moderate disease, the severe disease. So this is a spectrum of the disorder. And normal aging also, yes, they can have some cognitive dysfunction, but as I pointed out earlier, it is the way it affects the daily activities. So subjective. So somebody may say that he's forgetting, he's not able to remember, he's misplacing. So that will be more of a subjective cognitive impairment. Whereas when it goes to the stage of MCI, it is noticed by others. And when it is going to the stage of dementia, it is something that is affecting his daily activities. So it is the clinical history, and then that apart, while we do the neuropsychological assessment, so based upon how much deviation they come below the limits of the normality, so that also can help us to say whether it is a senile aging or whether it is dementia per se. So it is based upon the clinical history and the medical, the neuropsychological assessments. The second question was on
dementia. Sleep in dementia.
Sleep in dementia. It's a huge topic, by itself. And Alzheimer's patients, they are also prone to have early awakenings, poor sleep. And so there are several findings that has been looked into. And there are people who have started applying polysomnography, and they've started applying the Peterson sleep scores. So that is one of the evolving region in Alzheimer's. And a proper sleep hygiene is a very important thing that has to be advocated to patients with cognitive impairment. A sleep hygiene has to be told to the family and the patients while we encounter a subject with cognitive decline.
Thank you. I thought I'll add a little note on how non-pharmacological therapies are important in dementia. Some of them from the psychology perspective have already been talked about by Jwala, but there are others. So today, neuromodulation, especially transcranial direct current stimulation, and to a lesser extent, transcranial magnetic stimulation, are emerging as treatments for various early stages of cognitive impairment. They are also emerging as treatments for behavioral and psychological symptoms when they are troublesome. So that's one space to watch. Other such treatments of excitement include hyperbaric oxygen, which is getting some attention in various countries. And, there are various other biological treatments that are under trial for especially mild cognitive impairment and early dementia. If you then wind forward wind backward, really, into the ancient wisdom, to the past, there are procedures in Ayurveda, there are procedures in naturopathy, there are procedures in yoga that are extremely helpful for people with early and mild cognitive impairment, and even people with severe cognitive impairment and behavioral dysfunction. So in our clinic, for example, we, apart from neuromodulation, which I just talked about, we also offer people with various forms of dementia and other neuropsychiatric conditions, head and neck massage with medicated oil called Shiro Abhyangam. And it has a wonderful effect on calming the mind and on sleep. And we often combine it with mud packs for the abdomen, because most people, especially the elderly, including those with dementia, have got constipation or other bowel disturbances. And we combine it with reflexology, which is another very calming technique that one can use. And this combination of three treatments we find has been very, very helpful. And we have published data now in various venues about the efficacy of such holistic treatments. And of course, in terms of preventive health, there is a lot that ancient Indian wisdom can offer. Yoga, for example, is something that one can do as a mind-body exercise. It helps in various ways. Apart from cognition, it helps in maintaining physical health. It helps in maintaining bone and joint health. Indeed, you can even get people to do yoga sitting on wheelchairs quite safely. So in a sense, therefore, it's all about adaptation of various non-pharmacological tools. And I think when it comes to conditions like dementia, the parallel I draw from childhood is autism. What it requires from us is an open mind and a sense of collaboration and not competition. Not an either-or approach, but a rather inclusive approach. And that's something that I very strongly recommend everyone should consider, how non-pharmacological treatments can make a difference to dementia care. It's an emerging area, and it's an area of great interest worldwide today. And slowly, even the West, people are starting to move towards this as a potential solution, because everyone realizes that medical management is not for all. So I think this is something that I want to just highlight on World Alzheimer's Day. We seem to have taken all the questions in the box, but if there are any more, please do put them into the box. I'm going to ask each of our panelists to give us their sort of words of wisdom any final thoughts they have on this important day, World Alzheimer's Day. Dr. Mathur, sir.
आज के दिन कॉग्निशन जो मेमोरी है उसके बारे में जानकारी सब लोगों को होना जरूरी है. This is important for everyone to realize the cognition as an important asset of our health, and we have to look for the cognitive decline, particularly in the older people. And there are ways of preventing it, as has been mentioned, or reversing it. So we have to be watchful for this. And I would say in primary care practice, people should always try and ask about memory and definitely screen about the cognition for their patients, because then that is the point from where we will pick up the initial stages and the initial patients for further evaluation. And one more thing which I mentioned earlier also is taking care of the caregivers and promoting the information about proper caregiving for these particular patients is also equally important. Thank you.
Thank you, sir. Jwala?
Yes, I have two little comments. So I think, when we think of medical conditions, we're always thinking of fighting them. So whether it's cancer or it's COVID, we're always thinking of fighting it. But I think with dementia, let's not fight it. Let's accept it. And I think the moment we accept it, it's much easier to handle. I think like Dr. Krishnamurthy said, we have to sort of put a collaborative sort of effort in trying to work around it, rather than trying to fight it or change it, because that might not really be possible in the current situation. And I always see that families who can accept it faster are healthier, are able to cope with it better. And the other important point I feel is focus on what they can do. So a lot of the times, patients and their families are focusing or complaining about what they can't do this, they can't do that. And I think we lose what they're still capable of. One of our patients from Cogworks, she's had dementia for, she was one of the first patients I've seen at the beginning of my practice. And she's still she's densely amnesic. So she goes for yoga. 5 minutes later, I ask her, have you done yoga? And she'll say, what yoga? But she still stitches and she tailors, and she's taught all my interns how to stitch. So I feel we really need to focus on what they can do. And most patients are able to do a lot more than what we see. So I would say stop fighting and focus on what they can do.
Thank you. Dr. Subhashi, there's a question in the box which I think I'd like you to try and take. In a male Alzheimer's patient, syncope during micturition, any treatment, is a question from Dr. Suchit Bagde.
Okay. One is we have to see if there is any underlying cardiovascular risk factors, because cardiovascular risk factors are quite common in Alzheimer's. Sometimes they can have mixed pathologies, and mixed dementia, especially in the Indian setup, is quite common and high. And so if we see the imaging, it could be clinical, or even in the imaging wise, we see a higher number of vascular pathologies. So one should look into the cardiovascular risk factors in this situation, in this scenario, because micturition syncope in a male is not a typical feature of Alzheimer's per se. So the other causes of micturition syncope has to be ruled out.
And would you like to give us your final thoughts?
Yeah. So I feel there has to be more of early detection, and there has to be a lot of preventive strategies before we embark on the treatment and support. So first is early detection, early diagnosis. So we have to have more and more of screening, and there has to be approach to the medical community. The public has to be aware. They have to approach the medical community and have a proper screening of memory, even in younger individuals. So that's what we see in the Indian context. It's not that more than 65, even if someone young is having memory disturbances, they have to approach and get their screening of memory and the cognitive tests done. And the reversible causes, they can be up to 25%. So we should not label it as degenerative. We should look for the treatable causes, B12, thyroid, or a sexually transmitted disease, or so all these have to be ruled out before. And the other thing is autoimmune dementias. So these are all newer in the armamentarium, the newer in the diagnostic panels, and these have to be ruled out. Young onset dementia has to be given a specific importance because they are the breadwinners and they contribute to the very active, it's the very active period of their life that they are suffering with. So early onset dementia also has to be given very important attention. And other thing is this year's theme is post-diagnosis. So not only therapy, not only medical management, the caregiver support, the psychosocial support, the community-based interventions and policies. So all these have a major role. And yeah, so that is what I want to convey.
Thank you. As my own message, I thought I should focus a bit on prevention because it's better not to get it at all if you can. The one thing most of us forget is that the processes that cause dementia start in our 40s, possibly even in our 30s. So what we do early in life matters. We have data today that suggests exercise is important. And there is the magical figure of 10,000 steps a day, which is suggested as being something that can improve longevity in some meta-analysis and some studies. So exercise and something as simple as walking is probably important for all of us. Diet is important. There is much said about turmeric. There's much said about diversity of diet. There's much that has been said about the Mediterranean diet, but what people forget is that the Mediterranean diet goes with the Mediterranean lifestyle. So a meal is eaten over 2 or 3 hours and followed by a siesta. So just eating the meal is not good enough. It's also about the lifestyle, which brings us to the work-life balance. It's extremely important that we find time to keep our minds engaged with things other than just work. And so that balance of being stress-free and good, maintaining good mental health is probably also very, very preventive. It has been shown that hurry, worry, and curry are not just risk factors for gastric ulcers. Hurry and worry can be risk factors for dementia or indeed strokes as well. So I think it makes a lot of sense for us to focus on our mental health. Keeping our minds and brains active, the number of people we see who soon after retirement have a decline in cognition is quite amazing in clinical practice. So staying active mentally is probably something that all of us should do. And we should find different ways of staying active all through our lives. And when I say active, both physically active and mentally active. And finally, I think, before we get too westernized in our thoughts, our own culture has so much to offer in terms of diet, lifestyle, Ayurveda and yoga. And a little bit of study there, I think, is going to hold us all in good stead in the longer term. So those are my sort of thoughts about prevention. I'd like to thank my fellow panelists for joining us today, sharing their wisdom. I'd like to thank IAN for giving us this wonderful opportunity. Dr. Vankade says, thank you very much, great session. Thank you, sir. It's great because of all the participants who have joined us. So I'd like to say a big thank you to all the participants. I'd like to hand you back over to the IAN leadership, Dr. Surya and Dr. Meshram. World Alzheimer's Day, great session. Thank you all.
Thank you.
I think we'll wait for Dr.
Thank you. Thank you very much. Yeah,
Thank you.
Dr. Meshram, sir, or Dr. Surya.
Hello.
Yes, sir, you're audible.
Yeah. So we had a wonderful discussion, and I think it is very important that people recognize. You have talked about the diagnosis, memory. You talked about how to take care, the behavior, the diet, the yoga, the everyday activity. So I'm sure, though this is a disease where you think that you are going into a darkness, yet there are so many positive points. There's so many lights and the bulbs which can make the life even much better and productive in spite of a disease which has got so much problem. I think it's wonderful to listen to you, and I'm sure all of them would have been benefited with this. And what is good is this recording will be available on the YouTube channel of Indian Academy of Neurology, and you can always log in and tell your friends to look there and to view it. Once again, thank you all. I think Meshram should have been there.
So you're muted.
Dr. Meshram, can you please say the concluding remark on behalf of IN? We have answered all the questions, no?
Yes, sir. All the questions have been taken. Yes.
Yeah. Thank you. So,
I think
so we can.
Thank you for your dynamism in involving all of us.
Thank you.
We are all strangers in your midst. So thank you.
No, sir. And if you still want to know more about the how we are dealing with the Alzheimer's disease rehab part, so we got another webinar coming at 8 o'clock from the Indian Federation of Neuro Rehabilitation, where we are again going to discuss about the rehabilitation aspect, how to deal with people. And I think Jwala will continue to have there. So she has an extended hours of contribution towards the Alzheimer's disease. So I think 8 o'clock, IFNR channel. I look forward to all of you. Good night. Thank you, ESK.
Thank
Arvind
you.
Mathur
Thank you
sir,
very
my
much.
lecturer, and Subhasri and Jwala. See you again, sir. Good night.
Good
Thank
night.
you. Good night.